All right, let's get started with Chapter 4, Communication and Documentation. This chapter will protect you more than any other chapter in this course. Good documentation and good communication keeps the patient calm, keeps the scene safe, and keeps you functioning as a team. It also keeps you out of court, keeps your license intact, and proves that you did the right thing even many years later. This slide introduces the National EMS Education Standard competencies, specifically the preparatory section. I want you to think of this as the foundation for everything we do as EMTs. Before we ever touch a patient, start an IV as an ALS provider, or even begin an assessment, we have to understand the system we're working in and our role within it. Preparatory content focuses on three big things: how the EMS system works, how to keep ourselves safe and healthy, and how to navigate medical, legal, and ethical responsibilities. That includes things like consent, refusal, documentation, communication, and understanding the limits of our scope. A lot of these which we've already discussed. These topics may not feel as exciting as trauma or cardiac emergencies, but they're what's going to protect you, your patient, and your career. Everything in this chapter ties directly into real-world EMS practice. These standards are what the National Registry is built on, what protocols are based on, and what your agency expects you to know on day one. As we go through this chapter, I want you to think less about memorizing definitions and more about how this shows up on a call. Because in EMS, knowing how to communicate, document, and make ethical decisions is just as important as knowing how to treat the patient in front of you. This slide focuses on therapeutic communication, which is one of the most powerful tools that you'll have as an EMT, and one that doesn't come in a bag or on the ambulance. Therapeutic communication is how we interact with our patients in a way that builds trust, reduces anxiety, and helps us gather accurate information. If a patient doesn't trust you or feel heard, it doesn't matter how good your clinical skills are, your care is going to suffer. This includes things like interviewing techniques, knowing when to ask open-ended versus closed-ended questions, and adjusting how we communicate based on the patient's age, developmental stage, cultural backgrounds, or any other special needs. The way you speak to a scared child, an elderly patient, or someone with a language barrier should never be a one-size-fits-all approach. Effective EMTs learn to read the room and adapt their approach quickly. Therapeutic communication also plays a huge role in verbal de-escalation and managing family presence. On many calls, the family can either be our biggest help or our biggest challenge. How we communicate, our tone, our word choice, and our body language can either calm a tense situation or make it worse. These are skills that are going to keep scenes safer, patients calmer, and you in control without raising your voice. This competency shifts us from a patient-focused communication to an EMS system communication, which is how we operate safely and effectively within the larger EMS system. As EMTs, we're rarely working alone, and we're constantly communicating with others, with other units, dispatch, fire, law enforcement, hospitals, or even our partner. Clear communication here isn't optional. It directly impacts our patient's outcome and our scene safety. This includes knowing how and when to call for additional resources, whether that's another unit, calling for ALS, adding the fire department, or law enforcement. It also covers how we transfer care, both verbally and in writing, when we hand a patient off to another provider. A poor handoff can undo everything right that we did on a call. So this is where organized communication really matters. EMS system communication also means understanding team structure and dynamics. On the scene, everyone has a role, and effective EMTs communicate clearly within that structure, giving concise updates, acknowledging directions, and speaking up if something doesn't feel right. It also includes how we communicate over the radio, use of proper terminology, and interacting professionally with nurses, doctors, and other healthcare providers. The way we communicate reflects our competence, our credibility, and our professionalism. This is one of those areas where strong communication keeps things running smoothly, but poor communication just creates chaos. Learning how to function within this system, not just clinically, but operationally, is what separates a new EMT from a reliable EMT. This competency focuses on documentation. And I want to be clear and upfront, documentation is not just busy work. It's a clinical record, a legal document, and our professional voice after the call is over. Once we leave the scene, our patient care is judged almost entirely by what we wrote in our report. As EMTs, we're responsible for accurately recording our patient findings. This means objective data, what we saw, what we heard, and what we measured, not our assumptions and not our opinions. Vital signs, patient statements, assessments, and changes over time all matter. And really, if it wasn't documented, legally speaking, it didn't happen. This also includes understanding the principles of medical documentation and report writing. Our documentation should be clear, chronological, complete, and defensible. Vague statements like the patient's stable or no distress noted, these things don't protect us. What does stable mean? What did we really assess? And so forth. Good documentation tells the story of a call in a way that someone who was not on the call can follow it from start to finish. Later in this course, we're going to spend a lot of time practicing documentation because it ties directly into our patient's safety, continuity of care, and legal protection for us. Developing good habits now, early and intentionally, are going to make you stronger providers and a safer EMT moving forward. This final competency focuses on medical terminology, and this is one of the areas that can feel intimidating at first, but it becomes one of our strongest tools as an EMT once we get familiar with it. As EMTs, we're expected to use foundational anatomical and medical terms and abbreviations in both written and oral communications. This means when we're talking with our partner, giving a radio report, transferring care at the hospital, writing our PCR, we need to be using language that's clear, specific, and professional. Medical terminology helps remove any ambiguity. Saying the patient has chest pain radiating to the left arm tells a very different story than saying our patient doesn't feel good. The more precise our language, the better the care coordination and the stronger our documentation. This also matters when communicating with other healthcare professionals. Nurses, doctors, and paramedics rely on consistent terminology to understand exactly what you found and what you did. Using correct terms builds credibility and trust, and it shows you're functioning as part of the healthcare team, not just responding to calls. As we move through this course, you'll see medical terminology reinforced constantly in assessments, documentation, radio reports, and scenarios. You don't have to know everything today or on day one, but what you do need to do is start thinking and speaking like a clinician. This is what competency is all about. Communication. At its core, communication is simply the transmission of information from one person to another. In EMS, this can happen in two main ways: verbal communication, which is what we say, and nonverbal communication, which is our body language, our facial expressions, our tone, our posture, or how we position ourselves around our patients. And here's something important to remember. Communication isn't just about talking. A patient may be watching how you approach them, whether you make eye contact, how calm or anxious we appear, whether we seem confident or rushed. All of that sends a message to our patients before we ever even ask a question. Verbal communication skills are especially important for us as EMTs because it allows us to gather critical information. We use communication to get a history or understand our patient's chief complaint and to clarify what's actually happening with them. We also rely on communication to coordinate with other responders on scene, usually the fire department, law enforcement, or even other EMS units. Strong communication skills are essential when we're interacting with other healthcare professionals, giving radio reports, transferring care at the hospital, or documenting what happened on the call. Clear, accurate communication helps ensure the continuity of care and protects the patient and us as providers. If you take nothing else from this slide, remember, communication is a clinical skill. Just like taking a blood pressure or performing an assessment, it's something that we're going to practice, refine, and get better at as time goes on. Our patient care report, or the PCR, becomes a part of the patient's permanent medical record for this encounter. Long after the call is over, our documentation could be reviewed by the emergency department staff, quality assurance officers, our medical director, insurance companies, and even the patient's attorney. This is why what we write and how we write it really matter. Documentation also serves to demonstrate that appropriate care was delivered. It's how we show what we found, what we did, why we made the decisions that we did. If it's not documented in your PCR, there's no proof that it actually happened, and this can be a major problem for our patient and for us as providers. Good documentation doesn't just protect us, it also helps the others involved in the patient's future care. Emergency department providers, their admitting teams, and sometimes specialty services even rely on our reports to understand how the patient presented initially and how they responded to our treatment. When we talk about a complete patient record, we're talking about more than just checking boxes. A complete PCR helps guarantee a proper transfer of responsibility when care is handed off at the hospital or to another provider. It ensures nothing is missed and that everyone is working from the same information. Our documentation must also comply with requirements from the health department, regulatory agencies, and sometimes even law enforcement. EMS documentation is often reviewed for compliance, reporting, and public health purposes, which means accuracy and clarity are crucial. Finally, our documentation fulfills our organization's administrative needs. Our PCRs are used for billing, quality improvement, training, and system-wide evaluation. While these things may feel far removed from actual patient care, they're essential to keeping our EMS systems running effectively. As we move forward in this chapter, I really want you guys to start thinking about documentation, not just as paperwork, but more as patient advocacy, professional accountability, and legal protection, kind of all wrapped into one. This last introduction slide focuses on the communication systems that we'll rely on every single shift: our computer, radio, and telephone communications. These systems are what link you as an EMT to the rest of the emergency response system: our dispatchers, other EMS units, the fire department, and law enforcement. When they work well, scenes run smoothly. When communication breaks down, that's when mistakes, delays, and safety issues can happen. As an EMT, you must understand what your system can do, and just as importantly, what it cannot do. That includes knowing when to request additional resources, what information dispatch needs from you, and what limitations exist with radio coverage, CAD systems, phone communications, mapping software, etc. We also need to understand how to use the system efficiently and effectively. This means clear radio reports, concise updates, and professional communication. Radio traffic should be brief, organized, but purposeful, especially during busy radio times or high-stress calls. Remember, communication systems are not just tools, they're our lifelines. They connect you to help, to guidance, and to broader EMS teams. Using them correctly protects your patient, protects your crew, and keeps the entire EMS system functioning safely. As we move forward, keep the mindset: good EMTs treat communication as a clinical skill, not just a technical one. Now we're going to shift into therapeutic communication, which is honestly one of the most important and underestimated skills that you'll use as an EMT. Therapeutic communication means using intentional communication techniques and strategies to build the trust of our patients and establish a positive relationship with them. This includes both verbal and nonverbal communication. So not just what we say, but how we say it, our body language, our tone, our posture, and even our facial expressions. Patients don't just listen to our words, they read us. If you say, "You're going to be okay," while standing there with your arms crossed, looking rushed or annoyed, the patient is going to believe your body language and not your words. One of the goals of therapeutic communication is to encourage patients to express how they feel. This includes their pain, their fears, their concerns, and sometimes some emotions that don't even seem directly related to a medical complaint. A patient who feels heard is more likely to cooperate with us, giving us accurate information and trusting in our care. This doesn't mean that we're acting as a counselor. It means we're creating a safe space for communication. Simple phrases like, "Can you tell me more about that?" or "That sounds scary, I'm here with you," can go a long way in building rapport and trust from our patients. Ultimately, therapeutic communication helps us achieve a positive relationship with each patient. This relationship directly impacts our patients' outcomes, our scene safety, and how smoothly the call goes. Every patient interaction is different. What works for one patient might not work for another. Therapeutic communication is about us being flexible, observant, and intentional with how we interact with our patients. When this is done well, our patients don't just remember the treatment that we gave them, they remember how we made them feel. The Shannon-Weaver communication model. This explains why communication breaks down so often on EMS calls. So this model starts with the sender. This is generally us, the EMT. We take a thought, an instruction, a question, or an explanation, and we encode it into a message. Encoding just means how you choose to say it, the words we use, our tone, our volume, and even our body language. Then that message gets sent to the receiver, which is the patient, or their family member, our partner, a dispatcher, another provider, something like that. This sounds simple, but this is usually where things start to go downhill. The receiver then decodes that message, meaning they interpret what we say. And here's the important part. They don't just decode it based on our intention. They decode it based on their stress level, pain, fear, past experiences, and their understanding of medical language. So we may say, I'm going to try and start an IV on you, and that's the routine. But to the patient, they might decode this as, oh gosh, I'm really sick, or this is really serious, or I'm scared of needles. The same message, but a completely different interpretation. The last step is feedback. The receiver responds back to you, either verbally or non-verbally. The feedback might be a question, compliance, resistance, confusion, and sometimes even silence. As EMTs, our job is to pay attention to this feedback. If the patient looks confused, scared, or shut down, it tells us that the message didn't necessarily land the way we intended it. This is our cue to slow down. Maybe we need to rephrase what we're saying or simply just clarify. This model reminds us that communication is not just about talking. It's about confirming understanding. Therapeutic communication means you don't just send the message and move on. We have to watch how it's received and adjust as needed. In EMS, effective communication isn't optional. It directly impacts our patient cooperation, the scene safety, and the quality of care we're able to provide. Now I want you to actually look at this diagram, because this is what communication looks like on every single call, whether we realize it or not. On the left side, we have the sender. That's you. You're taking in the information in your head, decoding it, and encoding it into a message. Encoding it includes everything: our words, our tone, our volume, our facial expressions, and our body language. In the middle, we have the message itself. This is what we're actually trying to communicate. This might be a question like, where does it hurt? Or maybe an instruction like, I need you to sit still. Or maybe it's an explanation like, we're going to take you to the hospital and get you checked out. On the right side, we have the receiver. This is usually our patient who then decodes the message. And this is where we sometimes get in trouble because decoding is not objective. Our patients don't decode our messages based on any kind of medical training. They decode them, again, based on their fear, their pain, their past experiences, and the trust that they've built with us. So now look at what's underneath, the message or the noise. Noise is anything that's going to interfere with communication. And in EMS, noise is everywhere. Our noise can be literal, the sirens, the radio, our pagers, yelling family members, etc. But the noise can also be emotional or psychological. Pain, anxiety, alcohol or drugs, a language barrier, some kind of mental health crisis, or simply our patients just being scared. So we may give a perfectly clear instruction, but the noise surrounding it filters it out. The patient hears something different than what we meant. That's not because they're being difficult, it's because communication is happening in a chaotic environment. At the bottom of the diagram, we see feedback, and this is the most important part for us as EMTs. Feedback is how the receiver responds. Do they answer our question appropriately? Are they able to comply? Do they give us this look of confusion? Do they get agitated? Do they simply shut down? This feedback tells us whether the message landed or not. If it didn't, we just need to adjust. It's okay. We just might need to rephrase the question, slow down, change our tone, or how we said it. The diagram shows us that communication is not one way. It's a loop. And any good EMT constantly monitors that loop and adjusts in real time. If we don't take anything else from this slide, just remember, clear communication isn't really about what we say, it's about what our patient understands. This slide brings everything together. This is where communication really becomes a skill instead of just talking. The table shows factors and strategies that we should consider every time we interact with the patient. And I want you to understand this isn't a checklist that we memorize, it's just a mindset that we develop over time. Let's start with age. We're not going to communicate with a 4-year-old the same way that we're going to communicate with a 40-year-old or an 84-year-old. Our word choice, our tone, and even how fast we talk is something that has to change. With kids, it's simple language and reassurance. With older adults, it might be a slower pacing, a louder volume, and more checking for understanding. Next, we have body language and facial expression, and this is huge. Our patients are watching us before we even open our mouth. Crossed arms, rushing around, looking annoyed, and not making eye contact can completely shut down a patient. But on the flip side, if we're calm, we have an open stance, and a neutral or reassuring facial expression, this is going to build trust quickly. Our eye contact matters too. This is where culture comes in. In some cultures, direct eye contact shows honesty. In others, it can feel disrespectful or even threatening. So again, we need to make sure we're reading our patient and we're adjusting, not forcing our norms onto them. Clothing and our appearance also plays a role. Our uniform represents authority and professionalism, but it can often be intimidating as well. Be aware of how that impacts anxious parents, kids, or people who've had bad experiences with EMS before. Culture, education level, and environment. These all affect how messages are received. A patient with limited medical knowledge may not understand basic terms that we think are simple. A chaotic environment, such as a loud scene or family yelling, even poor lighting, all of these things are going to add noise to our communication and mean we may need to repeat or simplify our instructions. Let's talk about voice tempo and volume. I'm still working on these. Talking faster does not make us sound more confident. It usually makes us sound more nervous. Slowing our speech, lowering our volume, and speaking clearly can actually de-escalate some situations. And finally, our posture or gender considerations. Where we stand, how close we are to someone, and how we position ourselves can affect our patient's comfort. Be mindful of their personal space, their modesty, and their preferences whenever possible. The big takeaway from this slide is therapeutic communication is intentional. We're constantly assessing the patient, not just medically, but emotionally and socially, and we're adjusting how we communicate to meet them where they're at. This is what separates an average EMT from a great one. Anyone can ask questions, but not everyone can make their patients feel heard, respected, and safe. This is going to start with how we communicate. Every patient brings their own background to the interaction, and this is how it directly affects communication with them. Age, culture, and personal experience all influence how a person communicates and how they interpret what we're saying. Two patients can hear the exact same words from us and take them completely differently. Let's start with age. Kids and adults and older patients, they're going to process information differently. A child may be scared and overwhelmed, even if they don't say it. An older adult might have trouble hearing, might have vision or cognitive challenges, and that's going to change how we need to speak with them. This means we adjust our tone, our pace, our volume, and the words that we choose. Culture. This is huge in EMS. Our body language and our eye contact, that's not universal. In some cultures, like I said before, this shows honesty and respect, but in others, it can be disrespectful or even confrontational. So if a patient avoids eye contact, it doesn't automatically mean that they're hiding something or they're trying to be uncooperative. And the same goes for expressing emotion. In some cultures, showing emotions openly is to be expected. In others, expressing pain or fear or distress is viewed as weakness. This could mean that a quiet patient isn't always a stable patient, and a loud patient isn't always being dramatic. This is where personal experience comes in also. Patients have had past experiences with EMS or the hospital or even some authority figures that are going to shape how they respond to us. Some may trust us immediately, while others are guarded or anxious or even defensive. And this has nothing to do with us personally. It just comes from their personal experiences. The takeaway here is don't assume. We need to observe and listen and adjust. Our job isn't to make the patient communicate in the way that we want to make them communicate. It's to meet them where they are and get the information that we need to provide care. Having this mindset will make us a safer provider, a better communicator, and ultimately a more effective EMT, especially on those high-stress calls. We're going to build on the idea and talk about how our communication choices are going to either help or hurt our interaction. Let's talk tone, pace, and volume. These matter just as much, sometimes more, than the actual words that we're using. Our tone and our pace, they often reflect our mood and how urgent we think the situation is, and our patients totally pick up on that. If we're speaking quickly or loudly or sharply, our patients are going to interpret that as either anger or impatience or that something's really wrong, even if that's not what we meant. On the other hand, if we slow down, we lower our voice, and we use a calm tone, that's going to help de-escalate their anxiety. It's going to help build trust, and especially in those stressful situations. Let's talk ethnocentrism. This is what we view when we view our own cultural values, beliefs, or communication styles as more important or more correct than someone else's. In EMS, this can show up when we expect our patients to act or speak or respond in the way that we would. This can create misunderstandings and damage rapport. Just because something feels normal to us doesn't mean it feels normal or comfortable for our patients. This is also closely related to cultural imposition, which is when we actually force our own values or expectations onto others. This can look like dismissing a patient's beliefs, pushing them to communicate in a way that feels uncomfortable for them, or simply not respecting their cultural preferences during our care. As EMTs, our role is not to change a patient's culture or beliefs. Our role is to provide safe, respectful care while adapting our communication to meet their needs. Now we're going to talk about nonverbal communication. And this is honestly one of the more important parts of communication in EMS. Our body language often provides more information than our words. Before a patient ever tells us what's wrong, we can usually tell a lot about them just by simply watching them. How are they sitting? How are they moving? What are their facial expressions look like? And how are they breathing? In fact, without ever even exchanging a single word, we should be able to get a rough sense of the patient's mood or their emotional state. Do they seem anxious? Maybe they're a little guarded. Do they look angry? Are they in pain or withdrawn? All of this information matters and is really going to guide how we approach them. Their facial expressions, their body language, and their eye contact are all really powerful communication tools. Your patient may say, "I'm fine," but their body language is telling you a completely different story. We have to pay attention to both. Our own nonverbal communication is just as important. How we stand, how we position ourselves, our facial expressions, and whether or not we make appropriate eye contact all send messages to the patient, whether we mean it to or not. So let's say I'm standing over a patient, my arms are crossed, and I don't look real happy to be there. This can come off as intimidating or dismissive. However, if I kneel down, I have a calm posture, and I keep my body more open, it communicates that I'm here to help, that I'm present, that I'm attentive to their needs. Nonverbal communication really helps people understand the message that's being sent, especially in a high-stress call or an emotional situation where our patients may struggle to process the words that we're actually saying. When our verbal and our nonverbal communications match, our patients are much more likely to trust and engage with us. As we move through these next slides, keep in mind, what we do often speaks louder than what we say. Beware that nonverbal cues, ours and the patient's, are going to being aware of those nonverbal cues. Our nonverbal cues and our patient's nonverbal cues are going to make us much stronger as providers. When we're treating a patient in a potentially hostile environment, it's even more important that we're aware of our own body language. In a tense situation, our patients are usually watching us very closely. They're paying attention to how we stand, how we move, what our face is saying, and even our tone of voice. Small things like sudden movements or our crossed arms can really escalate a situation without us even knowing it. The goal in these situations is for us to stay calm and to try and diffuse the situation, not to escalate the situation. The first thing that we should do is definitely assess the safety of the scene. If it's unsafe, we back out and we get help. Our safety always comes first. Remember, me, we, them. When interacting with a potentially aggressive patient, avoid assuming an aggressive posture. This means we're not clenching our fist, we're not towering over the patient, we're not making any kind of sudden or threatening movements. We want to try and keep our stance relaxed and non-threatening. Eye contact is super important. But there's a balance, right? We want to make good eye contact, but we don't want to stare. Staring is often going to feel uncomfortable or confrontational to those patients, especially the ones that are already upset. We want to look at them when we're speaking, but allow a natural break. When we speak, we want to do so calmly, confidently, and slowly. A steady and controlled voice is going to help set the tone of the interaction. If we speak quickly or loudly, it's going to increase anxiety and potentially make that situation worse. Finally, we never want to threaten a patient, either verbally or physically. Even statements that seem harmless in the movement can be interpreted as threatening when emotions are high. Our body language and our words should always communicate we're here to help, not to control or punish our patients. Remember, how we present ourselves can directly affect the situation and how it unfolds. It's important that we stay calm and professional and aware of our nonverbal communication, and this could be the difference between a situation escalating or a situation settling down. This last piece of nonverbal communication focuses on physical factors. Things outside of the patient and outside of that can still affect communication. Physical factors, literal noise, like we talked about, in the environment, lighting, the distance between us and the patient, or even physical objects. These are all things that can interfere with how well our messages are sent or received. Poor lighting can make it hard to read facial expressions or body language. Standing too far away from our patients can make them feel like we're disengaged, but standing too close can make them feel threatened, depending on the situation. Cultural norms also play a big role when it comes into personal space. What we feel normal, like I said before, might feel uncomfortable to our patients or intrusive or that we're overbearing. This is why it's really important that we pay attention to how our patient responds. If they lean away or take a step back or appear tense, those are all cues that, hey, maybe we should adjust our position. Our gestures and our body movements are another critical part of nonverbal communication. Waving our hands, crossing our arms, pointing, and pacing, these all send messages, sometimes again without us even realizing it. And finally, our attitude towards the patient matters just as much as what we say. Patients can often sense our frustration or our impatience and even our judgment through postural and facial expressions. So make sure we're being mindful of the environment, respecting our patient's personal space, controlling our movements, maintaining a calm and professional demeanor. All of these things are going to help create a safer, more effective communication. And if there's one takeaway here, it's communication isn't just about our words. It's everything around us and everything we do. All of those things communicate something to our patients. Verbal communication. This is a huge part of what we do in pre-hospital emergency care. And asking questions is one of the most fundamental skills that you will use as an EMT all the way throughout your whole career. Almost everything we learn about our patients, what happened, how they're feeling, what's going on, all of those things come from the questions that we ask and how well we listen to those answers. One of the most important types of questions that we tend to use is open-ended questions. Open-ended questions are questions that require more than a yes or no. They're going to encourage our patient to talk, to explain, to give us some details. Whenever possible, we should generally start with these open-ended questions, especially at the beginning of our patient assessment and interaction. So for example, instead of asking, does your chest hurt, which is going to limit the patient to a yes or no, we would be better off to ask, what seems to be bothering you today, or what's going on today? This one question can give us a lot about the patient. The patient might tell us that they're having pain, they're having shortness of breath, maybe they're dizzy or nauseous or, whatever, something that we weren't even initially thinking about. Open-ended questions are going to help build rapport. They show the patient that we're actually interested in hearing their story and not just checking boxes. This doesn't mean that closed-ended questions don't have a place. It just means that we absolutely should start with the open-ended questions to kind of guide the assessment. And as we move forward in this class and in your training, you'll see that good communication isn't about us talking more. It's about asking the right questions at the right time and really listening to the answers. It's super important that when we're asking these open-ended questions, that we actually give our patients time to respond. I'm guilty. I'll ask a question and they seem to be taking too long or stuttering with their answer or kind of fumbling for words, and I tend to move on to the next question without really giving them time to answer the question that I ask. All right, Closed-ended questions. Closed-ended questions are questions that can be answered in a short response, generally yes or no, or even a number. These types of questions are important, though, when the patient can't provide long or detailed answers. If our patient's really short of breath or in a ton of pain or obviously critically ill, we need to ask some of these closed-ended questions to get to the bottom of things. They're going to help us get information quickly without overwhelming the patient. So, for example, instead of asking this long, drawn-out, open-ended question, I may say, "Are you having trouble breathing?" This is going to give me a fast and a clear answer, and it's going to help to guide our immediate care. Closed-ended questions, though, are useful when we're getting into our focused assessment, or we're taking vital signs, or trying to narrow down some specific symptoms. The key thing to remember with good patient communication, it usually involves both open and closed-ended questions. We start with the open-ended questions, we let the patient tell their story, tell us what's going on, and then we transition to these closed-ended questions where we can clarify the details, confirm our assessment findings, and really gather more specific information. As an EMT, learning when to switch between these two types of questions is a skill that comes with practice. It comes with experience and paying attention to your patient's condition. The more patients that you see and the more times that you do this, the better you'll get at it. When you use verbal communication effectively, along with good nonverbal communication, we're able to build trust, improve our patient care, and gather more accurate information. Let's talk communication tools. These are going to be techniques that we'll use every single day in EMS, whether we realize it or not. These tools are going to help guide our conversations, gather information, and manage our patient's emotions, especially during these high-stress calls. First up is facilitation. Facilitation simply means helping the patient to continue talking. This can be as simple as nodding our head when we're listening to them, or saying okay, or go on, or simply staying quiet and attentive. We're showing the patient that we're listening and it's safe for them to keep sharing information. Next is pause. This one's uncomfortable for a lot of new EMTs. A pause is when we intentionally allow there to be silence. Silence that would give the patient time to think or process and sometimes share things that they wouldn't have said if they felt rushed to fill in that quiet. Some of the most important information that we can gain from our patients comes after this pause. Reflection. This means restating what the patient has said, either in their own words or even a little bit slightly rephrased into our own words. So for example, our patient says, "I just don't feel right." We may respond with, "You're not feeling like yourself today, so you're feeling a little bit off." This lets the patient know that we heard them correctly, and it gives them a chance to clarify what we said if needed. Empathy. This is huge in EMS. This means acknowledging our patient's feelings even if we don't fully understand them. We're not saying that we agree, we're just saying that we recognize how they're feeling. So a statement like, "That sounds really scary," or "I can see why you're upset," these can go a long way in building our trust with the patient and to help calm them or reassure them in a situation where they may be uncomfortable or anxious. Clarification. This is something that we use when something doesn't make sense or maybe needs a little bit more detail. So this might be like, "Can you explain to me what you mean by that?" Or when you say you feel dizzy, do you mean you feel lightheaded or is the room spinning? This clarification helps prevent misunderstandings and it's going to improve the accuracy of our assessment. Confrontation. This is a tool, but it needs to be used carefully. This means addressing inconsistencies or concerning behavior in a respectful or non-judgmental way. For example, the patient says they haven't had any alcohol today, but there's a strong smell of alcohol. So we may say, "I'm noticing an odor of alcohol. Can you help me understand that?" It's about patient safety, not about accusing them or shaming them. Interpretation. This involves putting meaning to what the patient is saying, but this one we need to be cautious with. We're essentially checking understanding of the situation. So for example, "It sounds like your pain started after you lifted something heavy. Is that correct?" This would allow the patient to correct us if we misunderstood. Explanation. This is when we tell the patient what we're doing and why. This is going to help reduce anxiety and improve their cooperation. A simple explanation like, "I'm going to take your blood pressure now to see how your body is doing," can really make a big difference. And then finally, we have summary. A summary is when we pull everything together and we repeat the key points. For example, you started having chest pain an hour ago, it feels tight, it hasn't gone away, and now you're short of breath. This ensures accuracy, helps transition a care, and reassures the patient that we were in fact listening. All of these communication tools are going to work together. We're not going to use every single one of these on a call, but knowing how and when to use them is going to help make you a more effective EMT and a better patient advocate. In the next section, we're going to continue building on these skills and talking about how communication improves and impacts patient care and outcomes. Let's talk assessment techniques, mainly focusing on how we interact with our patients during our assessment. When we're interviewing a patient, our communication, like I've said before, isn't just about words. It's about how we show care and how we show compassion. One tool that can be really powerful during an assessment or a patient interview is touch. When we use this appropriately, touch can help convey reassurance, calm, and empathy, especially when our patients are scared or anxious or very vulnerable. That being said, touch should be used consciously and sparingly. Not every patient wants to be touched, and our cultural norms, personal boundaries, and past experiences are all going to play a role into how that touch is received. Generally, an appropriate touch might include something like placing a hand on a patient's shoulder or a hand on their hand if the situation and the patient allow for it. This type of touch can reassure the patients that we're present, attentive, and really focused on their care. It's also important that we know where not to touch. We should avoid touching the torso, the chest, and the face unless it's required for our assessment or treatment of the patient. These areas are much more personal and can easily make your patients feel uncomfortable, threatened, or violated if we touch them unnecessarily. As with everything in EMS, we really need to read our patients. We need to pay attention to their body language, their facial expressions, and their reactions. If our patient pulls away or stiffens up or looks uncomfortable, that's a sign we should stop and we should give them some more space. Touch should never be forced, and it should never replace our communication. It's just in addition to. So in the image here, you can see this EMT is providing care, but she's maintaining a calm and reassuring presence. She's also positioned in a way that appears to be more supportive rather than invasive, and the touch shown is appropriate for this situation. This is a good example of how when touch is used correctly, it can strengthen the patient-provider relationship. And from an exam standpoint, just think that questions about touch often focus on the appropriateness, consent, and patient comfort. In the real world, though, this is going to come down to professionalism, awareness, and respect. All right, so let's talk about some techniques to avoid now. This slide is really important because it helps us avoid some mistakes that may happen unintentionally, especially when we're just trying to help or are calming our patients down or we're trying to move quickly. False assurance or reassurance. This includes statements like, you're going to be fine, or everything is going to be okay. Even those statements are well-intended, they can actually be harmful. As an EMS provider, we don't always know the outcome, and we should never promise the patient something that we can't guarantee. This is going to damage their trust in us. A better approach to this would be like saying, I'm here with you, or I'm going to take really good care of you, or letting the family know, hey, we're taking really good care of your loved one, things like that. Giving unsolicited advice. This happens when we start telling patients what they should have done or what they need to do next without asking them. So for example, you should have come in sooner, or you really need to stop doing that. These can make our patients feel judged or defensive, which is going to shut down our lines of communication with them. Another thing to avoid is asking leading or biased questions. These are questions that are going to push the patient towards a specific answer. For example, you weren't wearing your seatbelt, were you? This kind of question can influence the response and compromise the accuracy of our assessment. Talking too much. This one's really common. Silence can feel uncomfortable, especially for new providers like we just talked about. But sometimes the best thing that we can do is pause and let our patients talk. If we're doing most of the talking, we're probably missing some information. Interrupting. This is closely second to talking too much. When our patients are interrupted, they may shut down or feel like what they're saying is not important. Even if we think we already know the answer, it's important that we let them finish. The patients often reveal key details at the end of their explanation. Another technique to avoid is using why questions. These questions start with why, and they can sound accusatory or judgmental, even if we don't mean them that way. Instead of asking, why did you do that? We should ask, can you tell me what happened? Next would be authoritative language. This includes commands or statements that sound controlling or dismissive. For example, you need to calm down, or I'm in charge here. While seeing control is important, communication should be respectful and collaborative. And then finally, speaking in professional jargon. Our patients don't understand medical terminology or all the acronyms that we're going to use or the shorthands that are used in EMS. Saying things like we're concerned about your SpO2 and your BP may confuse our patients or scare them. We need to use simple and clear language whenever possible. Presence of family, friends, and bystanders. This is a really common situation in the pre-hospital setting, and how we manage it can impact both our assessment and the patient's cooperation. It's important that we understand that friends and family can be valuable resources during our patient interviews. They may provide helpful information about the patient's medical history, medications, baseline mental status, or events leading up to the call. In some cases, they may also help calm the patient or assist with communication. It's important, though, that we allow the patient to actually answer the question. When there's family members there and they're oftentimes well-meaning, they tend to want to answer the questions for the patient. It's really important that we actually allow the patient to answer the questions whenever possible. Sometimes the family members want to take over or interrupt or try and take over the conversation instead of us being able to direct these questions to the patient. So we could say something like, I want to hear directly from them, or let me ask the patient first. We don't want to dismiss them, but it's important that we are able to obtain the information from the patient themselves. This is going to maintain autonomy of the patient and ensures that we're actually getting firsthand information. There's times, though, when the presence of others can become distracting or overwhelming or even impede with our care. In these situations, it's okay to ask them to step aside for a moment. We need to do this calmly and respectfully and professionally, of course, but we might say something along the lines of, I just need a moment to talk with the patient privately, or we can update you shortly. Remember, part of our role as an EMS provider is scene control. Maintaining privacy, reducing distractions, and creating a calm environment is going to allow for better communication and safer patient care. This is really important when we're discussing sensitive information, assessing a patient's mental status, or evaluating the potential for abuse or neglect. The key takeaway, though, is balance. Friends and family and bystanders can be really helpful, but our patients remain our priority. We need to use available information wisely, protect the patient's autonomy, and manage the scene in a way that's supportive and effective. Golden rules of EMS. These are foundational principles that apply to every patient interaction, regardless of the call type, environment, or patient condition. Eye contact. First, make and maintain appropriate eye contact whenever possible. Eye contact is going to show attentiveness, confidence, and respect. It's going to help build trust and let the patient know they have our full attention. Introduction and names. We always want to provide our name and use the patient's proper name. If you're like me and you're terrible with remembering the patient's name, I usually ask them their name, and by the time I'm a few minutes into the call, if I've forgotten it, I'll just refer to them as sir or ma'am. Introducing ourselves is going to humanize the interaction, and it's going to help reduce the patient's anxiety. Whenever possible, though, we can ask the patient what they want to be called. Let's say their given name is James, and we're typing that in our report, but they go by Jim. We would refer to them as Jim. Using someone's name is going to reinforce dignity and respect, especially in these stressful situations. Another golden rule is to always tell the patient the truth. This does not mean overwhelming them with all the medical facts and details, but it means being honest with them about what we know and what we're doing and what's going to happen next. If we don't know something, it's okay to say so. Our patients can usually sense when we're being dishonest, and trust is really hard to rebuild with them once it's been lost. We always want to use language that our patient can understand, avoiding medical jargon or technical terms when we're speaking with our patients and family members. Remember, just because something makes sense to us as an EMS provider, it doesn't necessarily make sense to the patient. We do this all the time, and we are familiar with that language and with that jargon, whereas they are not. Clear, simple explanations are going to be the easiest way to improve their cooperation and help reduce your patient's fear. And also, we need to be really careful about what we say about the patient to others, especially in front of the patient. Our patients can often hear more than we think, even when they appear to be confused or even unresponsive. Our comments made to our partners, the hospital staff, and bystanders should always be professional and respectful. This is going to also apply to your radio traffic and your documentation. And then finally, be aware of our body language. Like I talked about, our posture, our facial expressions, our movements, all of these things communicate just as much as our words. These golden rules, though, are going to help be the foundation of our professional EMS communication. They're going to help build trust and maintain dignity and create a safer and more effective patient encounter. These are the foundational principles that apply to every single patient interaction. Next, we're going to talk about emotional intelligence, which is a critical skill in EMS, even though it's not always talked about as much as clinical skills. Emotional intelligence is the ability to understand and manage your own emotions, while also recognizing and responding appropriately to the emotions of others. In EMS, this matters because we're constantly interacting with people during some of the worst moments of their lives. When we're able to control our own reactions and recognize what someone else is feeling, it helps us handle situations more effectively. Emotional intelligence plays a major role in diffusing conflict, especially when it's with the patient or their family members are anxious or scared or angry. It's also going to help us build rapport with the patients, which often makes our assessments much easier and it improves cooperation of the patient. When communication feels calm and respectful, patients are more likely to trust us and share important information. Emotional intelligence also improves how we communicate overall, especially in high stress or emotionally charged situations. And finally, it's a key factor in managing difficult calls, whether that's a combative patient or an upset family member or just a difficult scene. In short, emotional intelligence helps us stay professional, compassionate, and effective, even when the situation around us is chaotic. This is a skill you're going to develop over time, but being aware of it is the first step towards becoming a better EMT. Emotional intelligence is made up of several key attributes that all work together in our EMS setting. The first is self-awareness, which is understanding our emotions, our stress level, and our reactions in the moment. This means we recognize when we're frustrated or overwhelmed or emotionally affected by a call and understand how it might affect our behavior. Closely related to that is self-regulation. This is our ability to control those emotions. In EMS, this means staying calm and professional and focused, even when our situation is chaotic, emotionally charged, or personally challenging. Motivation plays a role as well. This is our internal drive to want to do well, to keep learning, and to provide good patient care, even when we're tired or stressed or dealing with difficult circumstances. Empathy is another critical component. Empathy allows us to recognize and understand when a patient or family member is feeling. Even if we don't agree with their behavior, it helps us to respond with compassion rather than frustration. Finally, emotional intelligence includes social skills, which involve how we interact with patients, families, coworkers, and other responders. Having strong social skills helps with communication, teamwork, conflict resolution, and building trust on scene. All of these attributes together help you function more effectively as an EMT and allow you to provide care that is both clinically sound and emotionally supportive. Emotional intelligence isn't something you either have or don't have. It's something you can actively improve over time. One of the more important steps is learning to assess how you personally react in stressful situations. Pay attention to what triggers frustration, anxiety, or impatience, and how those emotions show up in your behavior. Practicing mindfulness is another key part of this. That simply means staying focused on the present moment instead of getting overwhelmed by what already happened or what might happen next. In EMS, being mentally prepared helps you to think clearly and respond appropriately. It is also important to take responsibility for your actions, especially during difficult calls. Even when the situation is stressful or emotions are running high, how you speak and act still matter. Finally, emotional intelligence requires emotional intelligence requires considering how your actions affect others. Your patient, the family, your partner, and the rest of the team. Small choices in tone, body language, and communication can have a big impact on how your situation unfolds. One tool that really ties emotional intelligence into real-world practice is the Behavioral Change Stairway Model. This model was originally developed by the FBI to help manage hostage situations, but has been widely adapted for crisis management in healthcare and EMS. The idea behind it is simple. Before you can influence someone's behavior, you have to connect with them emotionally. It starts with active listening, truly hearing what the patient is saying without interrupting or rushing them. From there, we show empathy by acknowledging their feelings and concerns. When people feel heard and understood, it naturally helps build rapport. Once that rapport is established, you're in a position to exert influence, not through authority or force, but rather through trust. And when that trust is present, a real behavior change becomes possible. This approach is really effective in high stress or emotionally charged situations, and it reinforces the idea that emotional intelligence isn't just a soft skill. It's a critical tool for safety, communication, and patient care. Communicating with older patients. When we're communicating with older patients, our first impressions really matter. We always want to start by identifying ourselves and clearly explaining who we are and why we're there. This step helps to establish trust in the right way. It also is important that we present ourselves as competent, confident, and caring. Our tone and our body language and our pace of speech all play a role in how safe and comfortable a patient's going to feel in those stressful situations. One thing we need to be really mindful of is avoiding assumptions. Just because someone is older does not mean they're confused or forgetful or unable to understand what's going on. We should approach every older patient with patience, confidence, respect, and compassion. Speak to them directly, giving them time to respond, and always treating them as a capable individual unless proven otherwise. This mindset not only improves communication, but it also leads to better patient care and cooperation and better information gathering. When we're caring for older patients, it's important we understand that we may encounter behaviors like irritability, frustration, or even confusion. It's critical to remember that these behaviors are not normal and shouldn't be dismissed as just part of the aging process. There may be signs or symptoms of illness, pain, fear, or an underlying medical issue. And because of that, how we approach the patient really matters. We should always move slowly and calmly, both physically and verbally. Sudden movements or rushed communication can increase anxiety or agitation. Give the patient plenty of time to process our questions and respond. Avoid rushing them to finish their sentences. Silence can feel uncomfortable, but allowing that extra time will lead to better communication and more accurate information. By staying patient and calm and attentive, we're creating an environment where older patients feel respected, heard, and safer, which ultimately leads to better care. When we're working with older patients, it's important that we stay alert for signs of confusion, anxiety, difficulty hearing, or vision. Sometimes these issues aren't immediately obvious. We need to pay attention to things like delayed responses, them repeating their questions, difficulty following instructions, or just signs of frustration. One of the key roles is to help the patient feel safe and confident. They should feel reassured that we are in control of the situation and everything possible is being done to care for them. This confidence is going to come from how we carry ourselves, our tone, our body language, and how we explain what is happening. Calm and steady communication goes a long way in reducing fear and anxiety. And above all, we need to be patient. Older patients may need more time to process information and respond, and that extra time can make a big difference in how well they feel they understand us and how comfortable they feel. One thing to remember when we're caring for older patients is they don't always experience or report pain the same way that our younger patients do. They may tell you that they feel fine even when there's something significant happening, or they may not really understand what changes are occurring in their body systems. Because of that, we can't rely just on what the patient is telling us. We need to be really vigilant for objective changes in their vital signs, skin condition, mental status, and just their overall presentation. This means truly paying attention to what we're seeing, not just what we're hearing, and trusting our assessment skills when something doesn't seem quite right. Older patients can compensate well until suddenly they don't, so we need to be careful and observe any early changes and subtle changes in their vitals that could be critical. When the situation allows, it's helpful for us to give older patients a moment to gather a few personal items before going to the hospital. Simple things like their glasses or their hearing aids or their dentures can make a huge difference in their comfort and their ability to communicate once they arrive at the hospital. It's also important to recognize that many older patients are worried about what they're leaving behind, their home, their valuables, and even their pets. Taking a moment to acknowledge these concerns and reassuring them that someone will help look after these things if possible can go a long way in reducing their anxiety. Small acts of patience and consideration like this help to build their trust and improve communication and make a really stressful experience for them feel more manageable. When caring for children, fear is often much more obvious and much more intense than when we're caring for adults. Kids don't always understand what's happening around them, and a lot of what we see every day can be overwhelming from their perspective. Sometimes something as simple as just our uniform or the ambulance or even all of us walking into their house and standing around can be really frightening to these kids. Because of that, it's important that we're aware of how we're presenting ourselves and what the scene looks like through their eyes. Our goal is to reduce fear as much as possible while staying calm and using a gentle approach and helping the child feel safe before we ever lay hands on them to begin patient care. When we're working with children, comfort and familiarity can make a huge difference. So if the child has a favorite toy, a doll, a security blanket, it's okay for us to let them keep it whenever it's safe to do so. These items are going to provide reassurance and help reduce fear during an already stressful situation. Whenever possible, having a trusted family member or friend nearby can also be very calming for the child. And if it's safe and practical to do so, allowing a parent or guardian to even hold the child during our evaluation or treatment can help them feel more secure and cooperative. These small adjustments don't just comfort the child, they often make the assessment and care much easier for us as well. One of the most important things to remember when communicating with kids is to be honest. Kids are incredibly perceptive, and they can usually tell when something isn't being truthful and we're trying to distract them from what's really happening. If something's going to hurt, it's best to let the child know ahead of time, using age-appropriate and simple language. That honesty helps build up trust and often reduces fear even when the situation is uncomfortable. It's also important that we respect a child's modesty. Explain what we're doing before we do it. Keep them covered when possible, and maintain their dignity throughout the encounter. Being honest, respectful, and clear helps the kids feel safer and more control during the emergency. When communicating with children, our tone and our body language matter just as much as what we're saying. We need to speak in a professional but friendly way. We want to sound calm and approachable and reassuring, not rushed or intimidating. Maintaining eye contact helps build trust and lets the child know we're focused on them and there to help them. Whenever possible, we should position ourselves at the child's level. Kneeling or sitting instead of standing over them makes us feel less threatening and helps the child feel more comfortable and heard. These small adjustments, just in how we speak, how we position ourselves, and how we connect, can really make a big difference in how the kid is going to respond to us in an emergency. When communicating with patients who are hearing impaired, it's important to remember that most have normal intelligence and are not embarrassed by their hearing lost. The key is how we approach and interact with them. We should position ourselves so the patient can clearly see our face and our lips. Many hearing impaired patients rely on lip reading and facial expressions to help understand what is being said. If the patient uses hearing aids, be mindful of them during the care. Hearing aids can easily be lost during an accident or removed if a patient becomes confused, so take a moment to locate them and to keep them safe. If you're unsure whether a patient normally uses a hearing aid, ask a family member or a caregiver. Small steps like this can make communication much more effective and help the patient feel more comfortable and included in their care. Not to mention, hearing aids are really expensive. When caring for a patient who's hard of hearing, these are just a few simple steps that can make communication more effective. We should be prepared to adapt. Having a pen and paper available can be extremely helpful, especially when verbal communication becomes difficult. Writing things down can help reduce frustration for both us and the patient. If the patient's able to read lips, face them directly. Speak slowly, clearly, and distinctly, but keep our tone natural and calm. This helps ensure that they can understand what we're saying without feeling overwhelmed. And one important reminder, never shout. Raising our voice can distort the words and make lip reading more difficult, and this may come across as frustrating or disrespectful. Clear communication is always more effective than volume. As we continue talking about communication with hearing impaired patients, it's important to keep things simple and intentional. Take the time to really listen and try to ask short, clear questions. When we respond, to keep our answers brief and direct. This is going to help reduce confusion and make it easier for our patients to process the information in noisy or stressful environments. It can also be helpful for us to learn a few basic signs or phrases in sign language. Example signs like help or hurt or sick can go a long way in building trust and improving communication. We definitely don't need to be fluent, but showing the effort alone can help make the patient feel more understood and supportive. At the end of the day, effective communication isn't about perfection. It's about patience, awareness, and doing everything we can to meet the patient where they are. When we're caring for a patient who's visually impaired, one of the first things we should do is ask them how much they can actually see. Visual impairment exists on a wide spectrum, and many patients aren't completely blind. We should never assume what a patient can or can't see. Let them tell us. It's also important that we remember that visual impairment does not affect intelligence. These patients typically have normal cognitive ability, so speak to them directly, respectfully, and just as you would any other patient. One of the most important things that we can do is explain everything that we're doing. Let the patient know what we're about to do, what we're doing right now, and what will happen next. This helps reduce their anxiety, builds trust, and allows the patient to feel more in control of the situation. Clear, ongoing verbal communication is our most effective tool when caring for our visually impaired patients. As we begin providing care to the visually impaired patient, it's important that we maintain physical contact when it's appropriate. A simple reassuring touch, like letting the patient know where you are, can help reduce their anxiety and improve their sense of orientation. If the patient's able to walk to the ambulance, guide them by placing our hand on their arm rather than pushing or pulling them. This allows the patient to move at a pace that they're comfortable with while still feeling safe and supported. Any mobility aids that the patient uses, such as a cane, should always be transported with them to the hospital. These items are essential for their independence and comfort, and separating a patient from their mobility aid can increase confusion, anxiety, and risk of injury. Maintaining connection, clear guidance, and consistency throughout movement and transport is key when caring for these patients. Some visually impaired patients may rely on a guide dog, which can be identified by a special harness. These dogs are not pets. They're working animals that play a critical role in the patient's safety and independence. When possible, the guide dog should be transported with the patient. Keeping the dog with its handler can significantly reduce stress for both the patient and the animal and help maintain a sense of security during what already may be a very stressful situation. If transporting the dog isn't possible, it's important that we make arrangements for the dog's care before leaving the scene. This may involve coordinating with family members, friends, or local services to ensure that the dog is safe and properly cared for. Recognizing the importance of guide dogs and planning appropriately is essential for maintaining a respectful and a patient-centered care approach. When caring for a patient that does not speak English, it's still essential we find a way to obtain an accurate medical history. This communication may take a little bit more time, but it's critical for providing a safe and effective care. We need to start by determining whether the patient speaks any English at all. Even a few words or simple responses can help guide our assessment. When asking questions, we should keep them short, simple, and direct, and definitely avoid medical jargon whenever possible. Use nonverbal communication to our advantage. Pointing to parts of the body, using gestures, or demonstrating actions can often help the patient understand what we're asking or what we're concerned about. If a family member or friend is present and able to interpret, they can be a very helpful resource, especially in the pre-hospital setting. While this may not be ideal in every situation, it can help bridge the communication gap and allow us to gather important information until more formal interpretation services are available. Another helpful step in caring for non-English speaking patients is being proactive about communication before we ever arrive on scene. If there's a common language spoken in our community, it can be incredibly useful to learn a few basic phrases related to medical care, pain, or emergencies. There are simple tools that can help with this, like pocket cards that show common medical phrases along with their pronunciation. Smartphone apps and translation websites can often be useful in some situations, especially when we need to communicate quickly. That said, these tools are just meant to assist, not to replace proper medical interpretation. Once we arrive at the hospital, we need to remember to request a professional translator. This helps ensure that the information that is important is communicated accurately and that the patient fully understands their condition, treatment, and the next steps. At the end of the day, clear communication is a part of patient advocacy, and taking the extra time to bridge the language barrier helps build trust, improve patient care, and reduces the risk of misunderstandings. Mission critical communications. These are situations where any disruption or breakdown in communication can result in a failure of the task at hand. In EMS, these moments often occur during high-stress calls or complex scenes, or even a time-sensitive patient where mistakes or misunderstandings can have serious consequences. A key concept in mission-critical communication is the idea of a shared mental model. A mental model is essentially the picture each individual has in their head of what is happening on the scene, what the problem is, what the plan is, and what needs to happen next. For a team to function effectively, all members must share that same mental model. Everyone should be on the same page regarding the patient's condition, our priorities, roles, and expected actions. When team members are operating in different assumptions or different understandings, communications break down and the patient care can suffer. This is why having clear communication and concise communication, as well as confirmation of understanding, are so important during critical incidents. Mission-critical communication isn't just about talking. It's about ensuring everyone understands the situation the same way. Continuing the idea of a shared mental model, there are several key questions that every team member should be able to answer during a mission-critical situation. First, we need to be clear on what the focus priority is for the patient. In EMS, priorities can shift quickly, so it's important that everyone understands what is the main concern right now. Whether that's an airway problem, breathing, or circulation, or something else that poses an immediate threat to life. Next, we should consider the history of prior care. This includes what's already been done before we arrived, what interventions have been attempted, and how the patient has responded. Knowing this prevents duplication of care and helps guide the next steps. We also need to understand the patient's current state. This means their mental status, their vital signs, their overall appearance, and any changes that may have occurred since the initial patient contact. If one team member notices a change, that information needs to be communicated clearly to the rest of the team. Finally, we should ask ourselves, what are the patient's immediate needs right now? These are the actions that must be taken immediately to stabilize the patient or prevent further deterioration. When everyone agrees on those needs, our care becomes more efficient and more effective. When all of our team members are asking and answering these questions, the shared mental model stays intact. That's what allows mission-critical communication to work. Everyone knows what's happening and what matters most and what needs to be done next. We're going to break for part 2.